Thank you very much. Can you hear and see me?
Yes, we can.
Wonderful. I can't see myself. So I thank the distinguished members of this special committee for the opportunity to appear before you today to discuss safe supply. Um, I'd like to preface my remarks by saying your responsibility is grave, the stakes are very high, and the decisions you make in this session may echo for generations to come as they reach nearly every domain of life in the province. It's a decision that should not be hurried because it is, in fact, a social experiment of vast multi generational implications. It is also a human experiment without really informed consent because the evidence in terms of randomized controlled trials, meta-analyses, reviews is zero, as pointed out so aptly by Dr. Summers. The endpoints may be ambiguous, they may be grievous, or they may terminate with remorse. So the Canadian government has decided that tainted drug supply is the core part of a response to the opioid overdose crisis. And I'd like to emphasize the fact that if it were not for opioid overdose deaths that have catalyzed so much government intervention, we would not have these hearings anywhere in the country, because addiction has been festering in both the United States and Canada for decades without too much government concern as to its consequences. It is only because of the deaths, and justifiably so to some extent, that this has happened. The really important issue is to discuss opioids. I understand completely the inclusion of psychostimulants as well as other classes of drugs, but opioids are a unique class which may not have been highlighted by Dr. Summers, inasmuch as if treated with behavioral therapies or what have you, the dropout rate is well over 80%. And opioids are really quite a unique class of drugs because it is one of the toughest addictions to deal with. And aging out is relatively common for alcoholism, for smoking, and for some of the other drugs, but aging out is far rarer with opioid addiction. We also have to highlight the fact that opioids have different types of biological effects, one of which, if it's a full agonist, such as methadone, such as fentanyl, such as heroin, will promote a full-blown effect in the brain, except that certain drugs, like methadone, do not promote the highs and lows that other types of opioids do, such as heroin and fentanyl. Buprenorphine is another medication which has been approved for treatment, and it too does not promote the highs and lows that one gets with full agonists, which can be achieved by misusing prescription opioids such as hydrocodone or oxycodone derivatives. So I've been asked to proffer my opinion. It is based on 4 roles which I've been engaged in as a research scientist in public policy and as a member of the President's Opioid Commission, as an educator. My 4th role is that of a protagonist, a Cassandra, a person who tries to predict the future. And I'm going to focus today on a broad view of public health policy. The science that backs this up would consume many hours and probably about 120 slides. So what is the underlying reason? The underlying reason for safe supply is that it assumes that the government's responsibility is to provide pharmaceutical-grade substances with high abuse liability, with addictive potential, with adverse consequences to people with a substance use disorder. The alleged purpose is to prevent overdose deaths due to fentanyl contamination, to prevent overdose deaths due to unregulated quantities, and to prevent health effects due to contamination of the supply with fillers and toxic substances. So I make 4 points, and I would like to pose 4 questions to you. And of course, I'm open to questions from everyone. Will increased access to pristine drugs increase use? Our current and historical examples support that they will increase use. We can look at the history of tobacco to alcohol, marijuana, prescription opioids, fentanyl, cocaine, methamphetamine. Price and purity govern supply. Providing free drugs will reduce the perception of harm. And as you reduce the perception of harm, you increase use. And this has been throughout many of our national surveys starting from the 1970s. We will also see increased aversion as we've witnessed with prescription opioids. So the question is, does this committee have any evidence that supplying safe drugs will stabilize or decrease use and substance use disorders? The prescription opioid disaster catalyzed in the US is a paradigm of how increased supply of pristine opioids resulted in increased misuse, diversion. At some point, more than 70% of the people misusing opioids received them from friends, family, either bought or just taken or stolen. So as use will rise amongst youth and young adults, which are the most vulnerable population. The second question is, will increased use of pharmaceutical grade drugs ultimately have negative impact on overdose deaths, diversion, and so on? The focus on drug purity sidesteps a critical factor. Alcohol, tobacco, opioids are manufactured to pristine quality, yet they kill more people annually than other illicit drugs combined. Access is easy, use is normalized, the patterns of use, and that's the key issue, is the uncontrollable use by the user. Does this committee have evidence that safe supply has increased entry into treatment more effectively than improving access to treatment, drug courts, or other means of treatment entry? Regulating the purity of a drug and its dose omits a critical element of this problem. You cannot regulate whether or not people use a safe supply safely. How much, how often, what drug combinations people use. Substance use, the very definition is defined as uncontrollable drug use despite adverse consequences. Unless recovery and abstinence are the goals, regardless of drug purity, addiction will continue to take its toll on people from in utero to old age. The impact will continue to be negative regardless of the quality of the drug. Prescription opioids, again, I've done a very, very in-depth survey of how we got into this problem when I wrote a majority report of the President's Commission on the Opioid Crisis, is a perfect example of how increased access and normalization for any pain indication increased misuse, addiction, overdose, and deaths. The third issue is increased access. Will it increase risks to individuals? The term safe is asymmetric, as I've said, and refers not only to supply, but it has to refer to safe use. And the emphasis on recovery has to be critical. Does this committee have evidence that safe supply will be used as an incentive to motivate people into treatment and recovery? And is there any other benefits or consequences of safe supply? Does this committee have evidence that safe supply will be limited to pristine heroin, cocaine, crystal meth, which is not even it's not even a prescription formulation currently, and fentanyl? Or will subpopulations demand new psychoactive substances that appeal to them? New stimulants based on cathinone analogs, pyrovalerone analogs, new opioids. Are physicians willing to prescribe these drugs, including fentanyl, as they're currently doing in British Columbia? Will you regulate the use? There are thousands of potential new substances that are coming on the market that may rise to fashionable use as fentanyl has. And what will happen then? I can give you reams and reams of data and experiences over this. But in summary, my testimony does not address optimistic predictions. I would just like to do my narrative addresses the very important disconnect between safe supply and safe use. Based on the preponderance of historical and current evidence, I do not believe Alberta should take this step.
Thank you, Dr. Madras, for that presentation. And we're now going to open it up for question and answer with the, even though we've already done the question stuff, so hopefully we'll get some answers too. And we'll start with MLA Fry. MLA?
Hi, Dr. Madras. Thank you so much for your presentation. I was really intrigued by when you were talking about, I think your quote was, as you reduce the perception of harm, you will increase usage. So I'm wondering if you could relate that to, I know there's a conversation around a lot of political circles about decriminalization of things like opioids and harmful drugs that we know are also very addictive. So would you think the same phenomenon could happen through a decriminalization lens? If governments start to normalize the use of illicit substances, do you think that could also lead to more usage and pressure on healthcare systems?
Well, we already have seen it. We have certainly seen it, certainly in Canada and in the United States with regard to marijuana, which is legal now in Canada. It has been decriminalized in most states in the United States. And what we've seen is a vast increase in use, a rapid increase, not only in use, but in cannabis use disorder. From 2016 to 2019, we had 900,000 more people with cannabis use disorder in the United States. And we're seeing all the consequences associated with it. Perception of harm of marijuana has declined dramatically in the US amongst youth. And that's a very good example of normalizing use, increasing access, decriminalizing, and seeing that perception of harm has declined quite dramatically. Now, that is not true for certain other substances such as tobacco, which the use rates are declining, even though it's easily accessible. The tobacco products are relatively pristine, but there has been a very massive campaign to denormalize smoking in the country because of its health consequences, not because of its psychoactive effects. And as a consequence of that, use has declined amongst youth. And more youth are not using alcohol and tobacco now than ever before. So it is possible to legalize drugs and to decrease use, but the bar is extremely high, and we're going to lose a generation while we figure out how to promote prevention for specific types of drugs. Because tobacco prevention has been around for almost 40 and plus years. Alcohol ads and prevention has been around for as longer, not longer.
Oh, I certainly appreciate that. Mr. Chair, do you mind if I have a follow-up?
Yes.
Thank you. So,
I mean, I don't mind.
So I guess my follow-up question would be to Dr. Madras again. How would you describe your qualifications for being able to speak to this committee? I know we're looking at the list. I know you have many letters behind your name. We know that you're qualified, but for the people of Alberta who are listening in on this, can you please give us a little bit of background, or how you arrive at some of the high quality medical evidence that you give to this committee, and what perspective you're speaking from?
Well, I speak from a basic science perspective. I certainly can describe to the public as well as to my colleagues how drugs affect the brain in terms of the molecular, cellular biology, anatomical effects, behavioral effects, and so on, because that's been core to my entire career. But secondly, with regard to public policy, I was confirmed unanimously by the United States Senate to be the deputy drug czar of the United States between 2006 and 2008. And during that period and prior to, I had been studying the social, the psychological, the treatment modalities for substance use disorders quite extensively, because I organized the first and only course at Harvard Medical School at the time on addiction biology and addiction consequences and treatment. The course ran for 15 years, and during that time, it was a very extensive learning experience for me, because I always partnered with addiction treatment specialists and visited many treatment centers, sought treatment withdrawal centers. During the time that I was the deputy drug czar, I visited multiple treatment facilities around the country. Above all, I listened to people who were suffering with addiction, and listened to their families, and listened to their stories, and listened to how systems are failing them. And so I did an extensive program to try to catalyze screening and brief interventions for people who are not who are along the full spectrum of substance use, and managed to accomplish a number of goals during the tenure I was in Washington. Fast forward a decade, and the president appointed me on the Opioid Commission along with 5 other people, 3 governors, an attorney general, and a former congressman, Patrick Kennedy. And the chairman of the committee, Governor Chris Christie, asked me to essentially to shepherd the entire commission report. And in doing so, I summoned the expertise of all my friends and colleagues, as well as my own experiences, and likely composed between 65 and 68% of the commission report, using a number of resources, including my home base, which has addiction treatment specialists as well. So I've been in this field since the 1960s, when I was a graduate student, and I was the heir of the CIA LSD experiments. The LSD was given to me without my knowledge of what the source was, the origin, or its human use, and I was asked to study how it works at the Allen Memorial Institute in Montreal. And since that time, my commitment to understanding how drugs affect the brain at the molecular, cellular, and so on level has gone unwavering for the past 60 years. I was a graduate student at the age of 20 there.
Thank you, Doctor. MLA Yao.
Thank you so much, Chair. And again, Dr. Madras, thank you so much for taking the time to speak with us. We greatly appreciate that. You're probably very busy at Harvard Medical School right now. I have 3 points I'd just like you to expand on, if possible. Just the first point is, you mentioned something along the lines of this is a social experiment and that there's 0 evidence ultimately on this issue. The second point I'm asking you about is, you mentioned aging out. And if you could provide a definition of what that means. And you talked about how the aging out is different for opioids compared to things like ETOH and, alcohol and caffeine and whatnot. If you could expand on that. And the third is, you make a good point that we cannot regulate whether people will use a safe supply safely. So is it fair to say that despite access to safe supply of a pharmaceutical, that we will still have deaths? And I guess we could compare that to acetaminophen, which is a very safe supply that's available in any drugstore, yet one could argue that's one of the most lethal medications out there readily available for people because of its destructive abilities on our livers. If you could expand on those 3 comments, I'd greatly appreciate it.
Sure. I wonder if you could just repeat the first question, because with pre-pulse inhibition, I was listening to question 2 and 3 too carefully.
No problem. The first one was, I thought I heard you mention that this is a social experiment and that there's ultimately 0 evidence on this.
Yes. So basically, as your first speaker mentioned so eloquently, there is no real good solid data on whether or not you can administer cocaine or methamphetamine or amphetamine or any of the other substances, and what the long-term outcomes are going to be in that population. There may be short-term gains, but take, for example, the prescription opioid crisis that was catalyzed in the United States. At the time that it began to be ramped up, and there are at least 33 causes of the opioid crisis that catalyzed this problem. At the time that they ramped up, we had zero information on whether or not it is safe to prescribe opioids for longer than 3 months. And yet, the pharmaceutical industry, the patient population, certain, like the Joint Commission, the Federation of State Medical Boards, the Veterans Administration, a number of other organizations began to promote pain as the fifth vital sign and the absolute need to use opioids for these chronic conditions such as lower back pain, such as knee pain, and without evidence on what would happen over the long term, without evidence on whether or not they were even necessary. And what we have found recently, because the field was compelled to do the studies, is that NSAIDs, non-steroidal anti-inflammatory medications, are just as effective as opioids for the most common causes of pain. And chronic administration of pain of opioids after even 7 days puts the individual at risk for very prolonged use, because the opioids promote neuroadaptation in the brain that appears to be durable and, in fact, drives continued ongoing use. So I think that's really important. We don't have good, solid, high-quality evidence on whether or not safe supply is going to work. We have had studies in the country on trying to treat people with fixed doses of methamphetamine or amphetamine in clinical trials. They've all failed. I can tell you that or methylphenidate. None of them have because I was very much involved in medications development for quite a while. The second issue, the same question, was aging out. And the aging out is a well-known phenomenon. People quit smoking. A very high proportion of people who, when they're given warnings about smoking, quit. And most of them quit cold turkey without going to rehab or going to a treatment center. With alcoholism, if it's not severe, if they do not have a number of other confounding factors, psychiatric problems, social problems, and so on, and genetic disposition, many people can quit heavy alcohol use, problematic use, or even alcoholism without an intervention. So but opioids, the quit rate is very, very low compared to these other drugs. And so I think that pretty much answers the question on and safe supply. If anybody can point me to high quality research, I would be very willing to listen to it. From the best of my research on looking at the literature, it just does not exist.
Member, did you have a follow-up?
No, that's fine.
Okay. Perfect. MLA Rosen.
Thank you so much for being here. I have a couple of questions. Most of them will focus on statistics, so should be quite quick. As MLA Fry mentioned, you quoted that clean drugs reduce the perception of harm, which increases the use of the drugs, which I found to be such a profoundly simple but logical and straightforward statement. So I'm wondering if there is any data from the United States that suggests just how much the use of drugs increases in jurisdictions that provide quote-unquote clean drugs.
Well, I think the easiest data is just looking at Len Palauzi's work from the CDC, showing that as prescriptions of opioids increased, the number of overdose deaths increased almost in a perfect parallel line. And I think that by far the most profound example of what happens when you supply clean, pristine drugs to people is to look at the opioid crisis, because the data are overwhelming, they're abundant. Problematically, as of the last study that I have seen, about 65% of people who enter treatment for opioid addiction now did not begin with prescription opioids. That number was much, much higher in the early part of the opioid crisis. Now people are really initiating with fentanyl and heroin, and fentanyl is becoming the drug of choice. And in some places, heroin is not even available. It is only fentanyl and adulterated with cocaine or methamphetamine or prescription drugs or benzodiazepines. All that data, every one of the questions that you ask, I can provide citations for as a follow-up. I'd be delighted to do it.
I would love that if you could do that. I have another question then. On average, if we look at the death rate from opioids in the United States, how many of what percentage of individuals who die from use of opioids die from tainted or drug poisoning versus just overuse in a normal overdose?
That's a very important question, which I don't think we have solid evidence that people, if only we could ask them post hoc. There have been studies done by one of my colleagues, Dr. Hilary Connery, at McLean Hospital, in which she has interviewed people who went through an overdose but actually survived. And they were asked what were their intentions in taking the drug. Lamentably, about 30% roughly, and I have to get the actual figures because I don't have them memorized, but approximately a third were actually intending to commit suicide. And the others were, what percentage of the rest were unaware that they had tainted supplies versus non? Those studies, there's actually been a couple of studies in the US on doing that. If I'm trying to remember the breakdown, but it's not inconsequential that people are aware that they want to use the fentanyl and are pushing the boundaries to get a greater high. The problem with fentanyl, as with certain other potent opioids, is that they produce rapid tolerance, which means you need to increase the dose in order to get the same effect. And people, self-report that they're always chasing that first high. They want to get back to the point at which they were introduced to the drug intravenously, and it gave them such a euphoric feeling that they've developed tolerance to it, that they're still trying to increase the dose to achieve that same effect. So the answer is that I do believe there are some studies. I can excavate them for you. I don't have the proportions on hand, but I would say there is a significant but minority number of people who are actually using the drug with the view that they may die and are not in despair over it.
You could find those studies after the committee today. That would be wonderful. My last question is that you also made an interesting note that there has been a campaign against the use of tobacco by governments for decades. But interestingly, it seems as though governments in some jurisdictions are now almost campaigning for the use of illicit drugs and opioids. So I'm just wondering why you think there is a discrepancy there between the approach of governments towards tobacco versus illicit substances, and what or who is driving that?
Well, this is truly a political question, which I have many opinions on, because I have been very privy to a number of situations where I know what the pressures are respect to pushing illicit opioids, or respect to pushing illicit drugs. I can say that, for example, with marijuana, there was no grassroots movement among the general population to legalize marijuana in various states. It was a heavily financed campaign involving hundreds of millions of dollars to going state by state to trying to understand how to carve ads and legal documents to shape it according to those state desires. Primarily starting by medicalizing, and after medicalizing, legalizing. We're seeing the same movement now for hallucinogens. We've seen it for marijuana, and I suspect we're going to see it for opioids in the future. Kevin Sabat, who follows me, is going to be probably a bit more forthcoming with regard to all these pressures. But needless to say, there are big industries now involved in vast investments. There are over 300 companies now that have invested in promoting hallucinogens. And we're going to see this movement. The only people standing in the way of this movement are legislators. You.
Thank you, Doctor. Thank you, Dr. Madras. Sorry to cut you off there. That concludes our time for question and answer today, and actually a nice transition to Dr. Sabat. So thank you again, Dr. Madras, for your presentation